Yes, we are live on the YouTube. Let us wait for a few more minutes for others to join. Meanwhile, Dr. Nandini, can you introduce yourself to Nitish? Because no, we expect you to interact later on. Dr.
Sure.
Nitish Vora is on the left side panel here.
Yes. Namaste. My name is Nandini Sarvade. I'm a physiotherapist. I was in the US for the past 20 plus years.
Great.
And just 5-6 years ago, I have moved back. 5-6 months ago, I have moved back to India. Yeah, right now. So I am very interested in autism because I'm a pediatric physiotherapist, and I did my master's at NYU in developmental disabilities. And so I'm working on reflex integration a lot, primitive reflex integration, and using low-level laser has been very effective. I have done a lot with exercises also, but that takes a lot of time. And our kids don't have time. They need to get integrated faster so that they can start developing and progressing. So that is what I have been doing. And it is giving very good results. So I'm very excited about it.
About that, absolutely. Sure.
Sure. Thank you.
And nice to meet you. Welcome to India.
That was a good prelude to excellent talk that we are going to listen to. So I start the session here now. So good morning, friends. Welcome back to Saturday Club morning meeting. And today a very interesting topic that we have with us, and it is autism. Autism month going on. Internationally, these days we all hear a lot about autism. For this, so for this, we have an excellent speaker with us, Dr. Nitish Vora. He is a senior consultant pediatric neurologist and epileptologist from Ahmedabad, a good friend. He has multiple qualifications. He is MD Pediatrics, then MRCP, CHUK, FRCP, CHUK, CCT, British Board, Pediatric Neurology UK, and Post-CCT Epilepsy Fellow, GOSH UK. He is ex-consultant to Great Ormond Street Hospital for Children UK, and his areas of interest are epilepsy, brain injury, and autism. To his credit, he has several national and international publications. He has won several awards, and he is involved in a lot of organizational activity to promote pediatric neurology knowledge amongst pediatricians and the community as a whole. Very active academician who holds a lot of CMAs for us. Recently also we had one in Baroda also. So welcome Dr. Nitish to Saturday Club morning meeting. You have about 40 minutes to talk about your title of Facts and Myths about Autism, and we'll have 10-15 minutes of interaction. So over to you, Dr. Nitish.
Satish sir, thank you very much for the nice introduction, and thanks to inviting for this on such a nice platform. Good morning, all the friends. So we'll be, and I understand everyone here is, most of them are related to medicine.
Yes.
So I presume everyone knows something about autism, and we're trying to tease out with scientific evidence, what's right, what's wrong, and what we can do. And of course, I will try to keep it interactive. So if it's allowed, participant can reply in the chat box if they feel something appropriate to the question, to the answer.
Dr. Nitish, usually it doesn't help much because on the online platform it takes time for people to respond.
Right. No worries. So, but I will try to make sure it's
discussion once you finish the talk.
Will do, sir. Sure. Just thank you very much. So we'll start something on its autism basics, and then its facts and myths. So of course, April is Autism Awareness Month, and we want to see what we can do best for our children. So I'll start with the basic case which we see everywhere, day in, day out. So there is this 3.5-year-old boy, normal birth history, development up to 24 months. His first words were at 12 months, and he's developed a vocabulary of 20 to 30 words by joining 2 words by 24 months. So that was fine, everything fine. And then came the COVID. And since then, so from 24 months onward, his words disappeared. He stopped responding to his name. reduces use of eye contact and gesture. So it's not just eye contact, but also his emotions, expressions went down. He was less interested in surrounding. He screamed frequently, and parents said he seems to be in a world of his own. And I'm sure we all agree and had a proper assessment, and it looked like autism. So when we started, autism as such is a we can say neurodevelopmental neurobehavioral disorder, which has 3 core features: communication, that is both receptive and expressive, both verbal and non-verbal; social interaction and play; and stereotypies and repeated behavior. So these are the main core pillars, 3 pillars. But if you see, because of its interaction, the way brain develops, you have lots of issues associated, like sleep disturbances, may have seizures, someone have intellectual disability, issues of language, fine motor and coordination difficulties, anxiety, lots of sensory issues. So it's not just simple 3 pillars, but also so many other things associated with that. So parents usually ask how the diagnosis of autism made. Is there any test, blood test, MRI, or some specific test we do to get the autism diagnosis? Answer is no. It's a more complex process. It requires play-based observation of the child. Also requires formal assessment with team of professionals, which includes 3-4 people, and they have not subject but very objective criteria as well. And it's confirmed with diagnosis with the DSM-5 criteria. The purpose is also to identify etiology and comorbidities. Also the severity of autism, mild, moderate, severe, and what's child's having. It's just pure autism or a little delay or something combination or autism plus. It's very vital to recognize child's strength and weaknesses, because that's where you're going to make a plan for the child. Family counseling, their understanding, their dynamics and expectations are very important. So this is how it starts. So this is something basics, how it's diagnosis. And let's start now with our facts and myths. I presume everyone is doctor. So this is the first question from my slide. And when I put this slide, everyone gets a kind of eyebrows checked and said, it says enteric fever. Yeah, so if you think as a medicos, enteric fever, what's etiology? What's pathophysiology? What's the management? I think we all are very clear, whatever background we have, but we know what is enteric fever and what's done with that. But if I ask the same question to everyone, it's about autism. What's exact etiology? What's the pathophysiology? And what's the management? And everyone thinks, I know autism, but perhaps I don't have answers of all those things. And that's the biggest problem. So what we know about autism is it's a problem with the connections of the brain, its networks, and how the brain grows. So if you see here on this side, it says typical child, and it's a brain connection. So they are the short connection from point A to point B for any function. They are short connection, and they are more thick networks, and they are more faster. So child's receptive language processing and expression is very fast, and coordination, everything explains that way. Here with the child with autism, you have different roads for different connections. So more networks, thin networks, and for every question, you have different networks. And that's how you can think, if you're traveling to Ahmedabad to Baroda on the expressway, it's very fast. If you're taking small roads, it's longer. So these children with autism have many networks, longer networks, and it takes time to process the things. And that explains the sensory pathway, communication, motor problems, and the large head. So this is what we know. But what we exactly don't understand, and there are lots of schools of thoughts going on, is its pathophysiology. And once we are not clear on pathophysiology, people try to put different theories and remedies for that. So yes, we know it's autism. Some people say it's issue with the antioxidants. So let's give antioxidants because it's a stress. It's to do with monogenic transmitter disorders. So let's give something on that. We have glutamate and GABAergic issues. So give anticonvulsants and other medications. Someone says there's a hormonal imbalance, chemical kalucha. Let's give secretin, melatonin, oxytocin. Someone found it can be some immune issues as well. So now immunomodulators, someone said chelating agents. It is with mitochondrial dysfunction. So let's give omega-3 multivitamins. Someone says it's because of immune inflammation of the some of the neurons and connections. So now let's give anti-inflammatory agents. So now I'm not saying they all are right or wrong, but there are different theories, and that's where people get more confused about the what's right treatment and what's the management. So here we'll be focusing on facts and myths on what we know on the scientific evidence and what we can do based for our children with autism. So now Krish has been diagnosed with autism, and she has few questions. So first she asks, is this disease contagious? And we have to remind them this is not a disease, this is a condition. And it's a neurodevelopmental disorders. And of course, this is not contagious because if they're staying in say a combined family or somewhere, they do ask, can they share the food? Can they share the bed? Can they sleep together? It's all those things. So this is not contagious. Other question is, does this mean my child is mad? Duffer, manbuti, duffer, pagal hai? That's a question. And answer is no, he's not mad. But he has a special way of learning and communication, as well as he has many special strengths as well. So it's very unfair to say it's mad. We can say he's a special child. The way he learns, he has a special skills, and he's specially able child. There's always a question, should my child go to normal school? And that's a very pertinent question, and it's very difficult to answer or provide the provision. Because yes, we know most of the children with mild to moderate will go to mainstream schools, like what we have normal schools like, but with some extra help or inclusion. Unfortunately, we don't have much issue or much support available for the inclusion. And most of cities don't have inclusion available or they avoid. So those children suffer a lot with the moderate autism. Yes, for severe autism, there are very good special schools throughout big cities. So there should be some extra help available, and government is also trying to work on that. There is a lacunae, and I'm sure we'll be working on that, and it should improve. So there's always a question. So we know the diagnosis, we know what to do, and we are happy to whatever you say, but it's curable, right? And the answer is autism is not curable, right? It's a lifelong condition. People don't grow out of the autism, but yes, symptoms changes over the time and they get milder with the therapy and support. Could they live normal life? Again, normal life definition of normal is different for different people. So I think its purpose should be good communication and self-sufficient, independent life. And there's always a question, then why don't we see many autistic adults around? Truly speaking, when it's a bad or severe autism, they are usually institutionalized or they're homebound and they're locked in their home and considered as a mad people, unfortunately. And there's a huge increase in autism over the last 5-10 years. So that population will be there, more teenagers and more adults in coming decades. But also if you think some of the places where you don't need communication, and you will see people's communication, especially like back office work in the banks, post office, even some of our medical colleges and other places. So there are people who are very pertinent, very particular about their work, what they do, the way they arrange their table, exact time to time what they want to do, not talking too much with people, but they're very good with the work. And I think they may have some autistic trait. So we do see some adults with autism, but they're mild autism. And because they're in society, they are adjusted. So what we say is autism is manageable and it requires good family support, appropriate therapies, necessary interventions, and good educational social support. And with that, most children in mild to moderate group can manage their life. And we want to say they can live self-sufficient, independent life. They may have some difficulties, but that has to be worked on. So this is a good slide, and everyone likes this. And once they see this slide, they say, oh, one, fine. So that's okay. So we know legends who have autism or they're on the autism spectrum disorders. It's like Einstein, Microsoft owner, Bill Gates, Henry Ford, the owner of the Ford company, and everyone knows the Ford person, right? So Elon Musk. So they have autism, but they are on the spectrum. So people can be great legends as well. So don't worry that autism means bad or. But sometimes problem is as soon as I say this, mom says, okay, So my child is going to be one of the genius as well, right? And that's where we have to be very careful to say, yes, many children with autism have special skills and strengths, but it's individual, an individual person, and we have to see how the child grows. But we should support, and sky is the limit for them. So they can do whatever they want to be, engineer, doctor, professionals, business, whatever, but they can achieve that. And especially the children with a good cognition, early diagnosis, early support, and they do good. And yes, some children have varying degree of learning difficulties, including severe learning difficulties as well, but that's usually the secondary autism and severe autism. But primary, mild or mild to moderate should be fine. Then they say, okay, so is it rare? Are there not many children with autism, or is only my child who has autism and no one else? So it's very common. And I would say in last 5 years, the numbers have doubled in India. We used to say it was 1 in 150, in 1 in 100. Current data of 2021 is 1 in 76. And the recent data being analyzed, it says 1 in 40 to 1 in 50 children have autism. So it's a huge number, and it's going to get more explored as time comes. Now, something on autism, EEG, epilepsy, and seizures or medication drugs. So there are 3 questions. Should my child undergo EEG test or brainwave test? Is it likely that he will develop epilepsy? And he should be started on anti-seizure drugs. So let's understand first its interaction about epilepsy and autism. So there is an overlap. So it's not easy. There are conditions where epilepsy causes autism, so like say West syndrome or LGS or those kind of things. There are conditions where autism as a genetic condition cause epilepsy, and there can be common condition like tuberous sclerosis, which causes both. And there are so many other genetic causes and structural causes. So it's not that straightforward. If you see simple general population, incidence of epilepsy is just 1 to 2%, less than that. But incidence of epilepsy in children depends on the kind of autism they have, primary, secondary, brain injury, etc. It can be 5% to 38%. It's highly associated when child has cognitive and motor delay or have significant language deficits. It can include any kind of epilepsy. And if you think for EEG, so 20 to 68% may have EEG abnormalities, mainly temporal discharges, but it is possible. And if you see epilepsy, what happens is a bimodal peak. So less than 5 years. So younger children have chances of epilepsy, and the teenagers, they have more chances of epilepsy. So this is the data, but what's actually on ground? What happens? So let's about EEG. We heard there are lots of artifacts as well available, funny EEG things available as well, and it lacks sensitivity and specificity. So there is no routine EEG in autism. The child diagnosed with autism, should you have EEG as a routine? Answer is no. Yes, EEG should be done when there is a clinical epileptic seizures or epilepsy. When we are not sure, or someone is not sure that what's happening in this movement, these complex movements, are they epilepsy or not, then video EEG will be helpful. And also when there is a atypical autistic regression. So usually you see autism regression after 2nd year, in the 3rd year. But if you have regression by 1 year, 2 year, that's unusual. And beyond 4 years of age, it is more likely with something called as LKS, Landau-Kleffner syndrome, where you have excessive electrical discharge in brain, and that causes autism-like regression, or sometimes other immune disorders which can cause regression. So those conditions, less than 2 years of age or more than 4 years of age, we should consider EEG, but it should not be routine for all the children with autism. I hope things are clear, and it's simple. Now, medications. Should we start on medication drugs? Because as study says, there is a high chance of having epilepsy. Answer is there's no role of prophylactic ASDs as well. So let's start AEDs in case seizure develops, but there's no role of prophylactic medication. And also there's no role of medication to treat the EEG. There may be some EEG abnormalities. It doesn't mean that we have to treat with the medications. If there are clinical seizures, confirmed epileptic seizures, epilepsy, yes, they should be treated with medication. So this is rule of seizure medications with autism. Now some common questions. I heard that some specific exercise can help. Is it true? And answer is yes. With autism assessment, there are appropriate therapies which are made. And on base of that, specific occupational therapy, sensory integration, speech, play, behavior. They are the main therapy as per child needs at that stage and keeps modified as the child grows. But it's a mainstay of management. Other therapies, activities, they also help on similar principles and they can add to, but it does not replace the main therapies. Other therapies very useful: music therapy, art-based therapy, swimming, horse riding, pads, small activities. They're very helpful and they add to the primary therapies. They're in addition to what we should be doing. And something very important which we lack is relationship development interventions, where you have a buddy, so child who is designing with a buddy or a couple of friends, and wherever they go, they help with the communication, they go to market, social places, and this is how they train. And because of being a friend, same age child, it's very helpful. So that's RDA is helpful. Okay, I heard there is a specific diet for autism, it cures. And as soon as I say specific diet, people think of GFCS diet, dairy-free, gluten-free. There have been lots of trial. Elimination diet, either casein-free, gluten-free, dairy-free, does not work. Vitamin E or antioxidants does not work. High-dose vitamin supplements as such doesn't work. Special mushrooms, powders, padiki, faki, etc. doesn't work. It's like a fashion. People try, it comes and goes. And people do say, does it help? I say, yes, it helps to the companies who sell them, financial help. There is a role of fish oil, omega-3 and DHA, because these are essential amino acids and other fatty acids and things, and they're not made available in body, and they can be supplemented, and in a specific dose, yes, they have its role. So something more about diet. What should be done? Probably with the children with autism, people work with them, they know at early age, they are very thin and lean. They don't eat much. They have extremes of nutrition. And later age, they have specific diet. They sometimes binge it, lack of exercise, sedentary, and they put on the weight. So nutritional supplements, if child is deficient, definitely yes. And that's usually fibers of fruits and vegetables. Usually they are lacking iron, vitamin D, especially vegans, they lack B12 folic acid. So if that's the case, yes, we supplement as needed. It has been known that exclusive breastfeeding has shown some protection. So that's help. We must avoid food causing allergies, specific food which aggravates the symptoms like very high amount of sugar or caffeine, highly refined food, processed food, or chemicals containing e-substance food. But should be given appropriate foods, not an issue. And huge confusion because of GFCS diet. So gluten-free diet, if you think of celiac disease, we know celiac disease, what it is. And if you see the association, 50% children with celiac disease have autism. Now we think retrospect. So children with celiac disease, if you restrict the diet, their behavior, the diet, that everything improves. And it also helps with the symptoms of autism. But reverse is not true. If you see all the children with autism, hardly 1% children are celiac disease. So for celiac disease, GFCS is absolutely yes, agree. But reverse way, because may have celiac disease, only 1% child with autism should not give the GFCS diet. So only diet is required is healthy, balanced diet and supplements as needed. Okay, there is always specific medication, herbs, and all the different pathies, Ayurvedic, homeopathy, herbs, etc. Basically, there is no cure. There is no cure for autism, right? Neither Ayurvedic, homeopathy, allopathy, whatever. And in the allopathy, what's given, it's to control the symptoms, the bad behavior, anxiety, epilepsy, etc. So claim by anyone that we can cure autism is false. Yes, what happens is someone has a mild autism, therapy does help and child improves and behaves nearly normal. And that can be claimed by anyone that I did this, but that's not the fact. So there is no proven data, it's merely placebo effect. People have tried secretin, chelation therapy, heavy metals, but again, more harm than good. So please don't do that and don't suggest. In every few months, I'm sure we are met with some of the marketing things. Wow, we have got the miracle cure. It's truly amazing. It works in minutes. It's guaranteed in 6 months, it will be gone. Yes, these are good feel better effect, placebo effects, and it's more of a marketing gimmicks than anything else. So we should be careful of what's coming up. People do ask, and there was 10 years back, there's a question about MMR vaccine causing autism. So something to the immune system, and should we do immune modulation? Answer is no. So there is no role of antifungal therapy. People have tried some antifungal steroids. There's no role. Should we withhold immunization? So our MMR vaccine? Answer is no. We must give all the vaccines as per the schedule. Okay. Things are right, going the right pace. Satish sir, the right pace and things are, okay, no? Okay.
Yes, everything is going on well.
Perfect, sir. Thank you. So moving on, a few fantastic gadgets, hyperbaric oxygen and oxygen therapy. Would that help or cure? Answer is no. It has free radical injury potentials and more harm than help. So again, don't go into these kind of things. Something in fashion, transmagnetic stimulation. So you stimulate the brain and cells. And what happens with that? There is a polarity change. In some of the cases where with some of the behavior issues, epilepsy, sometimes it can be helpful, but no practical help in autism. So unfortunately, magical won't have no magic in autism. So TMS, no. And finally, always everyone says, or they come back and say, sir, we tried everything and then we went for stem cell. 90% people come and they say it was a rubbish. We unfortunately lost our 5 legs, 10 legs. And few says bad side effects. But we should understand what is stem cell and its role in autism. So it is under research only. And we need to explain to the families. So research has a different stages of trial, as we know. It has to be with ICMR rules and guidelines at approved centers only, like AIIMS. And it's always free because it's a research trial. People do, and I'm sure we are hearing a lot in media nowadays, this hospital was banned and this clinic is banned. And that's a very perfect thing, but there's a huge advertisement going on as well. So we should request and our parents to understand what's a research. It is not approved as therapy at the moment because it is not proven to be beneficial in humans at the moment, in the human trials, because there are issues with safety, long-term safety issues are there. And there was a big move of storing the cord blood or umbilical cord, like 70,000 rupees or something like that, and then monthly or yearly or 5-yearly maintenance. Again, do not store this for autism. It's not required. So no for stem cell therapy. Yes, it's good for research. And I agree, we are looking for stem cell as a big hope and for future, but it will take time, perhaps 5 years or coming 5 to 10 years. But at the moment, answer is no, and clear no. We know how autism works, when stem cell works, we'll not go into that. There's always a question, and it's in last few months. Wow, we got a new autism. That's virtual autism. So what's virtual autism? It's a genuine new autism? Answer is no. It's the same primary autism, same core features, and same therapy. But here we know the trigger, and it's a screen time. And especially post-COVID nuclear family where excessive screen time, it is a good outcome if appropriate and timely interventions are done, and especially cut back the trigger, cut back the screen time. But these children have huge behavioral comorbidities, and if not controlled appropriately in time, especially the anger, opposition, and violence. Okay. So these children with autism are always unique, totally interesting, and sometimes mysterious. I still have 5 to 7 minutes to go. This another question always comes. If my first child has autism, what's the chance of second child having autism? And here is this primary autism or secondary autism? That has to be known. If I say primary autism, it's a multifactorial, no specific bad cause. And with the primary autism, chances of next pregnancy, 5% chance of autism in the next sibling. Suppose male versus female. So my first child is a boy. What chances of autism second child? It's around 4 to 6%. And if first child is female who has autism, chances of autism second child is around 7 to 8%. So aggregate 5%, but first female child, second child having autism is slightly higher, and first male child's chances are around same 5%. If someone has a secondary autism means it's a specific genetic etiology, brain malformation, specific kind of epilepsy or tuberous sclerosis, those kind of things. We need to investigate thoroughly, and depends on what it is. The chances of autism can be 25 to 50% in the next child. So those children who have secondary autism, they should be thoroughly investigated. Their diagnosis should be made, and then family counseling so they know what to expect, and if they're planning family, what should be done. Okay. Now something on philosophy in this kind of conditions. So we know when there are bad conditions, chronic conditions, and there's no cure, chronic, frustrating situations, we want to look for all possible resorts, what is available, which may work, may not work, and sometimes even we are happy to take small risk as well, because we want to say by chance if it works. And Gujarati kehવાય છે કે ડૂબતાને તણખલું ભલું. So if someone is getting drowned, even the small piece of weed, they will try to hold on to, say, perhaps I may not get drowned. So there is always hope, and we should maintain hope. Family, doctors, therapists, they always want to do something beyond to help the patient. And that's also fair. And we also sometimes feel pressurized with the emotions. So do something. As a professional, we know sometimes we are able to manage our emotions. But families, when it's emotionally charged situation, people do get exploited as well. So this is a genuine problem. So what is our role as a doctors, as a professionals, as a medicos, as a therapist? First, no harm, right? We all agree on that. And second, we should provide family with the current base evidence, what's available, what's right and what's wrong as a professional guidance, not personal guidance. And leave the final decision to the family, because family sometimes ask, suppose sir, this was your child, what you will do? So don't get into that kind of fix. Say, okay, as a child, as a professional, what I expect, stem cell does with recent evidence, current evidence, this is what it does. These are the right things, wrong things. And at the moment, it is not approved as a therapy. If some proper place research is going on and you want to enroll, that's fine. I think that will be my answer. And we should all remain within our professional boundaries. That's very essential. So we always should keep hope alive for ourselves and patients and family, but in the right direction. So my last slide, something on important part of the autism as a summary. So early recognition, early referral, and early intervention is a must. And red flags we know, if child is not speaking by 2 years, not joining 2 words by 2 years, lack of eye contact, regression of social communication. So any of those things, refer early, and early intervention does help. Comprehensive diagnosis and assessment is must. So it's not just tick box of something and say, yes, it's autism. Because it's a stem for whole life. Stigma, positive thing, negative thing comes with that stem. So clear diagnosis with the strength, weaknesses, what's happening should be done. Family counseling and support is very essential, because biggest problem is that initial stage denial. People don't understand, they keep shopping around and they waste the important time. We know the window period of early 1000 days or in autism 2 to 5 years of age, which is very essential, where your language is developing, your networks are developing, and that's optimal stage. Once you diagnose or refer, or patient comes at the 6 years, 8 years of age, sir, we have done this, we went for this thing, homeotherapy, but now we feel it was wrong. Now it's 8 years, now do something. Unfortunately, it's gone, unfortunately. So proper diagnosis, counseling, what works, doesn't, it's very important, and spend sufficient time for that. It's a lifelong condition, no cure, but it can be managed. And what only thing works in autism is therapy, therapy, and therapy. So appropriate therapies, timely medical management, because there are lots of comorbidities and support is required for that, and their interventions is essential. Healthy, balanced diet. So don't get into the GFCFs or something unnecessarily. They should be on healthy diet. No to experimental therapies, so-called therapies, right? And our aim is they start communicating. So what we want to say to them, they understand. What they want to commit to us as a parents, as a family, as a professionals, as a teachers, as a friends, we should be able to understand that. And once we achieve that, first receptive language, processing and expression, better socialization, communication, with good support, good education, they can live self-sufficient, independent life to his or her potential. Thank you very much.
Thank you, Dr. Nitish. That was wonderful as expected. A very comprehensive overview of the subject for everybody to understand the things well. There are a lot of pediatricians here in the audience today. There are some comments pouring in. So first, to start with, my own comment is regarding this therapies. There are so many therapies being propagated or being used actually by many centers. And Dr. Samir Dalwai, who is a very well-known developmental pediatrician, and amongst IAPNs is very well-known. So Dr. Gopal has commented personally to me that he always talks about, Dr. Samir talks about, these children are centered over objects and patterns. And what is required is human-to-human interaction.
Absolutely, sir.
And he emphasizes only more on that rather than other therapies like, say, behavior analysis, etc. So your comments on that.
Sure, sir. So I think my is a balanced view that children depends on the age when they present. So initial ages, they need there are lots of sensory issues, and they have receptive language issues. So at that stage, they need sensory integration, occupational therapy, and communication support.
Okay.
So not proper speech therapy. And as the things move, then behavior issues comes in. So it's not the one fixed kind of therapy for the child. They should be reviewed every 3 monthly or so, and depends on strength, weakness, where they are. Appropriate therapy should be planned for that child. And very essential thing which we lack here in India is training to parents and home plan. For what a reason, I don't know. But people believe that you should come to me only in my center and I will give you therapy and I will not teach you anything. That's totally wrong. Parents should be the very important core part, because if they're coming to me as a therapist, I'm just spending 30 minutes, 60 minutes with the child. With the family, they're spending days and days, and 24 means at least 15 hours a day. So most of the world believes parents are the super therapist. You train them, you give them salient features, how to work on them, and give the home plan, and parents can work on that. And with the appropriate therapies help, that can be modified.
Wonderful. So that is what probably he also tries to emphasize by human-to-human interaction. In our practice, what you have heard, what you have experienced is that many children who come from abroad, when they visit Baroda, India, they often say this is a therapy for us, and it works because there are no human beings to interact with in their milieu there. So when they come to India, large families, joint families, a lot of other children around, and they start socializing well. Absolutely. So it proves that human-to-human interaction is more important. Absolutely. Other therapies are also important.
And absolutely, so with the home therapy, again, what it does, it actively engages parents and family with the child, which was lacking. So it absolutely human interaction is must, and that's what's lacking in the autism.
Right. Other thing is about the such a rapid increase in the incidence of autism. I mean, is it true or is it more of this virtual autism that you talked about?
No, sir. I think both. Means lots of factors. So genuinely, there is an increasing trend, maybe because of environmental factors, diet, nuclear family, screen time. There's also awareness. People previously were not ready to accept the diagnosis, so that's also a fact. So awareness at every level, doctors, therapists, patients, and also there's a post-COVID. We have seen a huge rise, and that's again being isolated and more screen time. So I will agree, sir, with all these points.
One Dr. Hemant Sant, who is a very regular member of our group, he is a gastrointestinal surgeon. He has posed a question: before labeling child autistic, are there any investigations to rule out gastroneuro conditions, for example, lactose, gluten intolerance, inflammatory conditions, and other neurological conditions? Yes.
Sir, in broadly, answer is no. But some of the children who has celiac disease or obvious food intolerance, where we know child present at 6 months, 12 months, weaning food, they have constipation, diarrhea, means failure to thrive. Those children, yes, they need appropriate investigation, whether it's celiac or what's required. But there's a very, very small population. Most of the children, they need proper assessment and they should start on therapy. And as such, autism does not require any specific investigation to confirm the diagnosis. Yes, for some of the patients for etiology, especially secondary autism, we may have to do appropriate investigations.
Dr. Sital Desai, pediatrician from Bangalore. She has mentioned about this virtual autism.
Yes.
He's asking, are there any other modifiable factors to prevent autism?
So one is human, as we said, human-to-human interaction. So when a nuclear family, child is with the babysitter and parents are working, I think there, if parents can just give 2 hours a day, so half hour each by them in different sessions, it can improve a lot. So good social interaction, human interaction, taking child to the play area, garden, somewhere where they have interaction, those things does help. But that's not the standard kind of cure therapy. But yes, it definitely helps to cut down the effects.
Yes, Jagdish, by your comment.
Yeah. Is there any role of functional MRI in diagnosis of autism? That is one thing. Second, some people give Adderall.
Sorry, sir.
Adderall, adrenergic stimulants.
Yes, sir.
I have seen some prescriptions in children in US. So is there any role of that? And difference between ADHD and autism sometimes becomes difficult.
Sure, sir. So I'll take all the three one by one. So first question was
functional MRI.
Functional MRI. So so there are functional MRI even so as a research, there is a role of fMRI. Yes, there is also a role of tractography. So functional MRI, what we're talking about is you stimulate either speech, specific motor part, and you see what part of the brain lights up, and that's fMRI. And we know that children with autism, because of network connection issues, their areas are wider. So for me, Broca's, Vanessa, they are very, very specific areas. But in children with autism, they are wider area. But just to diagnose them by fMRI is not possible and not just going to help. So standard criteria should help. Research is helpful. So at the moment, there is no role of fMRI to confirm or not confirm diagnosis. That's one thing, sir. But yes, it is working. It has its role. Even the tractography, in the research, it has proved the width of the tracks compared to normal population. If you see the cohort and see the child's tractography, the autism children track sizes are large, thinner, but complex tracks. So that does help as one of the points, but still it does not make any sense at the moment for practical use. So that's one thing. Second thing regarding adrenergic drug. So yes, there are lots of issues, and as I remember film Munna by MBBS, ये सब chemical का लोचा है, and brain works with the chemicals. So there are lots of theories on glutamate and secretins, serotonin, even the adrenaline. But how it works, what it does, no one knows. It's all random. So people are trying, but there is no proven data. Even if I use the word which I have not shared here, nowadays people who are coming from US, they'll be talking about fecal implantation. fecal implantation, right? That's something new happening in the US. So they remove the patient's own poo. They do some analysis, and they try to put back the specific gut bacteria into that, and they implant back into the tummy. And so many things are happening, and people are trying so many things. Even like we say, lactobacilli, they help with the tummy, or my gut feeling, or gut brain axis. So they are trying on different bacteria and different probiotics and different things, and they start claiming it works. So these are all things in research, trials coming up in fashion, but nothing proven so far. And last questions are yours: ADHD and autism. Okay, so autism, your core features are social communication, communication difficulties, social play integration, sensory issues, and repeated behavior. And they may be hyperactive as well. That's autism. ADHD, that is attention deficit hyperactivity disorder. So in a different setting, so not in one setting, sirf mere ghar pe bachcha tufani hai, nahi, should be at different places, my place, other place, school, everywhere. And that's hyperactive, lack of attention, impulsiveness. So all those, at least 2 of them, and that's ADHD. Some of the children with autism, they have behavioral difficulties, and as a part of their spectrum, comorbidity, autism is be around 40%, aggression around 30 to 40%, later age, OCD, obsessive compulsive disorders, and other affection disorders, around 50%. So it is comorbid. So children with autism may have ADHD as associated, but reverse way, child with ADHD does not mean he has autism. So autism and ADHD do coexist, and especially children with autism, behavior issue is more common.
Right.
I hope, sir, it's
Thank
clear.
you. Yeah, thank you.
Thank you.
Sir.
We have Dr. Nandini to have a long comment on this, but before that, we'll take up Dr. Jagdish's comments. Dr. Jagdish, please.
Thank you, Dr. Pandya. As usual, a very, very informative, nice talk. What I wanted to just bring forth are 2 major issues. One is the problem with autism is that every child is different. And accurate assessment is extremely important to see what are the strengths, weaknesses of this particular child, comorbidities, etc. One of the best papers that I have read recently is in JAMA Psychiatry just about a month back, where they have shown correlates between 3 different types of autism on neuroanatomical basis. In fact, they call it what is called as endophenotypes. Like we have in asthma, they have endophenotypes in autism itself, which shows that there are probably different clinical syndromes of autism within what we call autism right now, or the umbrella term of what we call autism. And I think that is a very important thing in the future, because the therapy that is given to autism right now is like, one size fits all. They do the same thing for every child. And that may not be the right thing. I can remember that I had a couple of children with autism where I've told the mothers to give up their jobs and told them to be after this child for at least 6 to 8 hours every day. And the outcome has been really satisfying, especially when they are detected with autism at very early ages, let us say at 1.5 years or so. The second point which I wanted to make is that the therapy of autism is so varied from place to place. There is no standardization. And there is no proper training, I feel, because everybody does something totally different from what another person does. For example, in Bangalore, we have got about at least 6 centers doing autism training, and each one does his own thing. And I cannot find any uniformity in what they are doing. So the issue is that how do we standardize, therapy? Nobody really has looked into this. We have one Dr. Pratibha Karanth, her ComDeal Trust, who's doing one particular form, which is pretty effective. Nimans does its own thing. St. John's does its own thing. Dr. Nandini Munkur Center does its own thing. The point is, parents get confused because then they start shopping and trying to see different kinds of therapies. So how do we standardize therapies in autism? How do we define this clinical syndrome in more detail? And then, take it forward. These are some of my questions.
Sir, first comment, I totally agree. And that's what we discussed, that individual child has to be assessed, their strengths, weaknesses, and again, the therapy plan doesn't remain same for same child. So same child every 2 months, 3 months has to be assessed. Plan has to be reassessed. Again, what has been achieved, next plan, if something not achieved, different plan. So I totally agree on what you said as a first point. Second point, I totally agree, but difficulty is we don't have even standardized things for even most of things, and government does not have direct control. So like stem cell, we know, everyone knows it's wrong, but there is no strict legislation to control them. Same with therapy. In the Western countries, there are standard protocols, and if someone wants to visit autism.org.uk, it does give a good insight for therapies. So what includes in therapies and their standards, what to be done for parents, something for professionals. So it does give some standardized criteria. But again, because there is no standard treatment or standard therapy, people do whatever they like, appropriate as a professional. And still, I'm happy as a professional what they do, but now it's becoming a business, and that's getting a big problem. And I don't have any answers. And perhaps, sir, you, Jagdish sir, Satish, and you senior guys can guide us, because I don't know.
I think it's more about, Jagdish, addressing to you also. It's more about pediatricians taking a lead on this. Like we have certain guidelines on certain diseases. We had some white paper on autism also a couple of years back. We can review that. I mean, we can take up as a body. And you, Dr. Nitish, also you are part of this AOPN, no?
Sure.
India Academy of Pediatric Neurology. I think we should all get together and redo the guidelines where these various therapies should be looked into in a critical manner, and have some consensus on when to use which therapy for which child, rather than as a blanket use in all the children. I think that makes us responsible as pediatric body to come out with the guidelines, rather than saying the same thing again. And so anytime when we discuss this developmental disorders, we all pediatricians are very much worried that what do we do with these children? We diagnose, but then the therapy that follows is not always satisfactory. The follow-up is not satisfactory. So I think over a period of time, we need to sit together and come out with some consensus guidelines.
Dr. Pandya,
Yes.
Pandya, one small comment also. Another tragic thing which I've been looking into for the last couple of weeks is what happens to adult autism. Once this child grow out of it, are there facilities to take care? In fact, Dr. Amdekar and there's a NGO which are looking at how to set up a facility for adult autism. And I was trying to look at whether there are any guidelines on what are the requirements for setting up such a center. And unfortunately, nothing is available. What should be the facility, how it should be. So we don't have any kind of guidelines on many things in autism. And I think it's high time that somebody starts taking this and doing it in a really proper professional way.
That somebody is you only, Jagdish.
No, Baba. हम लोग कितना करेगा, सब चीज थोड़ी करते, asthma, autism, everything we cannot do here.
Sir, something to add. Sir, what you're saying is absolutely true. There's a lack of support at every stage, especially in adults. But the biggest worry, what we have and what we am seeing, is there's an explosion of autism over last 5 years and over next 5 years as well. These children, as they grow, they have a huge behavior issue, affection issue, OCD, aggression, all those issues. So, and especially at the teenage, with the mainly we know 4:1 ratio of the boys versus girls. So that testosterone and everything kicking in. There are huge issues, and how to handle them, because family is not able to cope with them. And these children, we know there's extreme difficulties. They are giving high dose of sedations, or they're locked in the room. And our system is again not geared up for that. And even with the mild to moderatism, we'll have quite a few behavior issues. So I think the behavior part is coming up as a big thing over next 5 years, and it's going to be very challenging.
Thank you. Now, so before we end the session, finally, we'll have comments from Dr. Nandini. She's a physiotherapist, worked most of the time in US and now back in India. She had given a beautiful talk on reflex integration a couple of years back in Saturday Club morning meeting. So today she's here with us, and I invite her to make her comments on her experiences about dealing with autism with certain therapies that she is using. Over to you, Dr. Nandini.
Thank you, Dr. Pandya. Yes, I have been working in developmental disabilities for many years now. I have worked in day schools, in the US and also in institutions where they have adults living with developmental disabilities. I have seen everything. I have worked with many different therapies, starting with brushing protocol and sensory integration. Also, there is a therapy called MNRI, which does reflex integration using exercises. And latest, like for the past 5 years, I have been doing reflex integration using cold laser or low level laser therapy. So what I have seen in all of my patients with autism, ADHD, learning disabilities, dyslexia, is that I check their primitive reflexes, and there are about 18 reflexes, starting from the Moro reflex to fear paralysis, all the spinal gland, ATNR, STNR, all the way, all of the reflexes. And all the children with autism have these reflexes that are unintegrated. They are all retained at different levels, from mild to severe. But most of them have all the reflexes which are not integrated. Now, as you all know, what is a reflex? There is a stimuli and there is a reaction. The child has no control over it. So when you have the Moro reflex, which is the first reflex when the child is born, little bit of sudden light, sound, movement, something will create this reaction. And that is how they react to it. But by 3 to 4 months of age, the Moro reflex is integrated in a normal child. But in our special children, they are not integrated even at the age of 3, 5, 6, 7. So they are still with the slightest sound, with the slightest light, with anything, they go in a fight or flight status. So that until you can integrate all those reflexes, they will be functioning in this type of a mode, that is all reflex action. They are not able to bring the thinking to the frontal lobe and do a good decision. So decision making, everything gets affected, and they are always trying to function in the fight or flight. At the mild, moderate, and severe levels, they have different severity of the reflexes. But I have seen in my practice, there was a 4-year-old girl who came, and she was always very fearful. There would be a knock on the door or the doorbell would ring, and she will go in so much of a fear situation. She could not function. She would go and hide behind her mom and try to save herself because there was this sudden doorbell. But when I was able to integrate her reflexes, even not even completely, somewhat integrated in 2 sessions, because the low level laser is very fast working. Her mom told me, after 3-4 days, the girl started sleeping better and she was not fearful. When a new guest would come, instead of just crying with fear, she was curious and she would go to sleep. So these are all my experiences, a lot, and I will talk about it later. But yes, one thing I think we can do is that if pediatricians can start in your well baby visit or well child visit, if you can start checking some primitive reflexes like you do for the hip dysplasia and things like that, you always do. So if you can just do a few reflexes testing, and then if you see that, okay, this is not age appropriate, then you can immediately, even at 6 months of age, refer the child, no diagnosis, but just that this reflex, the Moro, which was supposed to be reflex integrated months ago, is not integrated. So do something about it. And I wish physical therapy schools would also do more of this education.
Thank you, Dr. Nandini, for those comments, because this is something which we do not hear much about. So we'll have part 2 of your talk about reflex integration in various conditions. Yes. More emphasis on autism. So I think we plan that talk sometime later in the next month, that is in the month of May. So thank you, Dr. Nitish, for a wonderful talk and a beautiful interaction. Thank you all for interacting so well after the session, after the talk. And in fact, I have learned a lot from this talk. So we carry on with this. And Dr. Nitish, we will be very happy to invite you sometime later again, to talk about other neurological, issues in pediatrics. So thank you. Thank you all. We end the session here. We meet next Saturday again. Thank you.
Thank you very much, sir. Thank you.